Dustin.
Thank you, Jose. Let's jump right in. So I enjoyed Jose's sort of about me with the map, and so I thought I would do the same thing. My name is Dustin Jacqmin. I'm very excited and grateful to be with you today. I have a little bit of a cold, so I apologize if my voice is a little funny and cuts out, but I won't let that get in the way of us having a very fun and educational morning slash afternoon together. So I was born in the state of Wisconsin, which is this funny shaped state in the northern central United States, in a city called Green Bay. I think most people around the world, if they know Green Bay at all, it's because there's an American football team there called the Packers that are, somewhat popular around the world. But other than that, Green Bay isn't famous for very much. When I graduated from high school, I went to college at the University of Wisconsin, which is in the state capital of Madison. I got my bachelor's in nuclear engineering and then a master's and PhD in medical physics. I did my residency training in medical physics down in Charleston, South Carolina, which is one of the oldest cities in the United States, the oldest European settled cities in the United States. And then after residency, I came back to Madison and got a job at the University of Wisconsin in the hospital, in the radiation oncology clinic, and I've been there ever since. I've been there for about 10 years. Just a reminder, you got an email about this from Emily earlier this week, but there's some additional resources for the course that our group put together for all of you. Specifically, there's a plan quality checklist supplemental document. So it kind of goes through all of the checks and has some text details about what to check and some of the nuances. And we just uploaded that for you. And then there's a Excel spreadsheet that is a book of checklists, kind of the generic one for kind of all patients, and then ones for different site-specific treatments. And so there's one for lung, one for abdomen, one for brain, and you'll find that as well on the Google Share Drive in this additional resources folder. So go check those out. It's a good way to kind of have all of that in one place and to be able to refer to it really quickly. So we hope you enjoy those resources. Today's talk is on plan quality review for lung radiotherapy. We'll be primarily covering definitive or curative intent lung radiotherapy. So things like conventional fractionation, so 2 gray per fraction, 60 gray and 30 fractions. Somewhat newer are these moderately hypofractionated regimens where you go to 60 gray, but you do so in 15 fractions or maybe 40 gray and 15 fractions. These are often used for really large lung tumors that are too big for SBRT, but would maybe benefit from some hypofractionation. And of course, lung SBRT, kind of the classic 50 gray and 5 fractions. We'll be covering that as well. Palliative lung radiotherapy will primarily be covered in session 12 on June 15th, along with other kinds of palliative radiotherapy. But I will discuss it a little bit today, and contrast it with the other types of lung radiotherapy. So you've seen this diagram a few times. High level overview, we'll be talking about patient assessment and treatment intent, and then simulation, treatment planning, communication, and what to do if you find deviations during your physics plan review process. So let's start with patient assessment. Patient assessment is really fact-finding, right? Learning as much as you can about the patient before you start your physics plan review so that you have the proper context for, what to look for during your plan review. And when thinking about lung radiotherapy, it's good to take a look at the physician's prescription and any documents related to that, maybe the physician's consult, and try to understand what is the intent of the physician and what is the dose and fractionation that we're going to be using for this patient. So the number of fractions are important. Are you doing conventional, moderate hypofractionation, SBRT? Is the intent palliative versus definitive? This might impact, whether you are more aggressive with coverage versus trying to protect organs at risk more. In lung radiotherapy, we see the full spectrum of treatment frequencies. So SBRT patients are treated every other day, most often. Conventional lung radiotherapy is done daily, Monday through Friday. At least here in the United States, those are the days of the week when we treat, 5 days per week. But we also treat twice per day, or sometimes called BID, when we do lung radiotherapy. And so it's good to know what this is. The treatment frequency will often impact the dose objectives because of the amount of radiation being delivered per day. And so it's important to keep that in mind. In lung radiotherapy, we're often treating one target or multiple targets, right? So sometimes we're treating the lung and the mediastinum, or if we're doing SBRT, we might be treating SBRT to multiple lesions. And so getting a sense of the number of targets and how that's going to impact normal tissue dose is good to do up front. The location of the target, is it central and maybe going to impact dose to the bronchus or the trachea, or is it more peripheral and you have to worry about the brachial plexus or the chest wall? Getting a sense of location will help, prime you to look at the right organs at risk and make sure everything is contoured. And finally, often with lung radiotherapy, we're not just treating the lung, but we're also treating regional lymph nodes. And so it's good to get a sense of what the physician's goals are ahead of time. There's certain special considerations for lung radiotherapy that you can learn about from the physician consult and from their intent. Pacemakers and implantable defibrillator devices are often near or in the same plane of treatment as lung radiotherapy targets, right? Very often pacemakers are placed sort of in the upper thorax. And so often doses to pacemakers are going to be higher in lung radiotherapy. And so it's really good to screen for these for lung radiotherapy patients. Lung radiotherapy, we have respiratory motion, which is this predictable periodic motion. And so very often we employ motion management strategies, and often the physician will choose that strategy before planning begins. And so it's a good opportunity to see what the physician intends to do and to take that into consideration. Occasionally, we'll have lung tumors that are near the abdomen, and the physician will choose to order the patient to withhold food and fluids before treatment. This is sometimes called NPO, or no food by mouth or nothing by mouth. There's kind of different phrases that different hospitals will use to describe this. But the goal is to decrease the size of the stomach to keep it further away from the diaphragm and further away from the dose being delivered in the thorax. So it's good to screen for this. If the patient has had previous surgeries, it's good to note that. That might impact if you've had previous radiation, or if you're doing any image registrations. You might be registering images pre and post surgery. And this can impact, the accuracy of those fusions or the difficulty of those fusions. And finally, some patient-specific conditions. Is the patient able to lie down flat? Is the patient able to hold their arms over their head? These types of things might impact the positioning strategy that you end up using for the patient. Lastly, previous radiation. This is a good time to try to determine if there has been any previous radiation and to collect that information as part of the planning process. In my experience, lung radiotherapy is a site where we often end up treating one area and then coming back and treating another area, particularly with SBRT. And so it's often the case that patients have some history of previous radiation when you're treating the thorax. But it's good to screen for not just lung radiotherapy, but breast radiotherapy, esophageal radiotherapy, and neighboring sites like head and neck and the abdomen, because these types of treatments can overlap with lung radiotherapy. Even if there is no overlap between treatments, low dose can overlap among treatments and create areas of high dose outside of the treatment volume. And finally, if the patient's treated somewhere other than your clinic, it's important to request DICOM information about previous treatments if possible. Sometimes this isn't always possible. Sometimes there isn't a secure way to send that information from one hospital to the other, but it's always worth asking to see if the hospital can provide that information, because it can make it a lot easier to account for that radiotherapy. I wanted to share what our standard operating procedure says for requesting DICOM files from other clinics. So what we request by default is PDFs of treatment summaries for previous treatments. This is just a nice way to see what did the plan look like on paper, what was the prescription, how was the plan normalized. You have a DVH there you can look at and get a sense of what was, how was the plan optimized and things like that. DICOM CT, structure, set, plan, dose, so kind of the basic things that are part of a radiation therapy treatment plan in the DICOM format. And then finally, PDFs of treatment plan documents. The treatment, I'm sorry, I did it in the wrong order. So the first thing I was talking about was the treatment plan documents. But treatment summaries are different. Treatment summaries are a record of which plans were treated and for how many fractions. Most patients start treatment and then finish it. And so you can assume that the plan was, delivered to completion. But sometimes patients don't finish their treatment, and you want to account for that. Sometimes a physician will add on additional fractions at the end if the patient is doing well and the side effects aren't as bad as expected. And so it's good to get a sense of exactly what was treated and whether the treatment was treated to completion. Often DICOM isn't available, especially if the clinic doesn't store it indefinitely, or if it was planned on a treatment planning system that didn't produce it, or if it was planned 20 years ago and they didn't have DICOM files from that period of time. And so if that happens, basically get whatever you can, treatment field parameters, aperture shapes, even if they're like just drawn on paper, isodose distributions, dose volume histogram statistics, anything that gives you a sense of like what the patient received in the previous course of radiotherapy can help you with your decision making. So here's our first clinical example. The background is the patient was treated for malignant neoplasm of the supraglottic larynx for one course of radiotherapy, and then they returned for a separate course of radiotherapy for non-small cell lung cancer. So on the left here, you can see the head and neck treatment. On the right, you can see the lung treatment. The planning team initially excluded the significance of overlap because the target volumes didn't overlap, and they thought, oh, we don't have overlap because these targets are separate from one another. We don't have to worry about it. But in actuality, the kind of the moderate medium dose lines overlapped such that there was a 100 gray hotspot between the two volumes, pretty close to where the brachial plexus is. So this is a really dangerous situation. Luckily, it was caught during physics review. The plans were reoptimized, and we went from having a 100 gray hotspot to basically a normal level of overlap at the, I want to say this is like the 80% isodose, so like the 50 gray level. So by catching this during physics plan review, we were able to prevent potentially a very serious side effect to the brachial plexus. But just, it's good to keep in mind if you're treating in the lung, you should always be looking above and below in the head, neck, and abdomen to make sure you're not going to overlap with previous treatments in those body sites. Let's move on to simulation. So, the first thing we check is patient setup. This is positioning and orientation and immobilization. In lung radiotherapy, immobilization really goes hand in hand with motion management strategy. And the immobilization will change quite a bit depending on how you're performing motion management. And we'll see that on the next slide. So I won't get into that too much now. Another important consideration is that the majority of lung radiotherapy patients are treated with their arms up. The only reason that we don't do that is if the patient really can't get their arms up over their head. We do this to get the arms out of the way of the thorax so that we have beams entering the thorax and not through the arms. The arms, of course, are highly mobile and difficult to reproduce in terms of their position. So getting them out of the way is better than trying to position them reproducibly in the treatment fields on a day-to-day basis. But sometimes patients can't put both arms over their head. Maybe they have a frozen shoulder, previous injuries. Maybe they're just old and their mobility has decreased over time. So, if you can, it's good to have the ipsilateral arm over the head and the contralateral arm at the patient's side. Occasionally, you have to have both arms down. When you do this, I like to have them tucked directly at the patient's side as straight as possible. A straight arm position is more reproducible than any sort of a bent arm position. There's an infinite number of ways you can bend your arm, but there's only one way you can have your arm perfectly straight. And then pressed up against the side, that's pretty reproducible too. If you have an immobilization device like a back lock, kind of packing the arms in with the back lock on the outside of the arms can help make the position more reproducible. But this is kind of like a backup plan. The ideal situation is to have the arms up over the head. So these are examples of positioning and immobilization protocols used for our clinic. I wouldn't necessarily say they're the best or ideal. I think we do pretty well, but I know there's some other systems of immobilization out there that are just as good or better. But I just wanted to give some examples. So on the left here, we have a palliative lung treatment. You can see it's a relatively simple, low-tech mobilization or positioning strategy. We have a wing board with pegs for the patient to hold on to, a mattress underneath them, a knee cushion. Generally, in our clinic, we don't use any sort of, vac lock. We don't use compression for these cases. You can, if the particular application warrants it. If the palliative disease you're treating is highly mobile, you can do some compression. You can do some additional mobilization. But generally, we keep it simple. and use a relatively, simple setup to allow the simulation to be conducted quickly. Really, the primary consideration is patient comfort and achieving a position that is reproducible. But we don't necessarily use some of the tools that we use for lung radiotherapy in other situations. Another situation
وخلي
is
بالك
where
عشان
the patient.
نسيت كوز الفيزيكس هذا.
I'm sorry, is there a question? I didn't catch that. That's all right. If you have a question, please put it in the chat, and Jose will make sure that I see it.
Yeah, I think it was somebody that wasn't muted. I'm trying to
Okay.
figure it. Yeah.
No big deal. So if you're going to be doing free breathing for definitive lung radiotherapy, then you'll want something that will help make sure the patient is reproducibly positioned each day. So a vac lock is a great device, although there are other devices out there you can use. And then you'll want to have, most often something that will reduce the extent of the respiratory cycle, like compression. And I have another slide on compression in a few slides, but I just wanted to kind of mention that here, where we have patient who's getting a 4D-CT. They're going to be treated free breathing, but we're applying some compression with in this case a body fix system, so a plastic sheet over the patient and a vacuum pump that pumps the air out and creates a seal with compression over the patient's chest. Of course, we have the back lock here that will allow reproducible positioning during treatment. This forms sort of a clamshell, so below the patient is positioned with the vac lock, and above they're held in place by the plastic sheet. So this is a really good way both to immobilize the patient as well as apply some abdominal compression. In contrast, when you're treating lung with breath hold, you don't want compression, right? You want the patient to be able to take a breath freely. And so in this case, we have a simpler mobilization that we use. We have this is a kind of a half body mold underneath the patient, a vacuum sealed mold, a vac bag. And of course, the patient's chest is free to take deep breaths. We'll place a marker on the patient so that we can track their breath hold. But this is sort of a simpler setup for breath hold because we're relying on the patient for immobilization by taking a breath and holding it. So these are some examples of immobilization for lung radiotherapy.
Okay, Dustin, can you go back to that slide?
Yeah.
There was a question that is relevant to this slide. In the case of scoliosis, so that the patient can't lie down, how would you simulate?
Oh, good question. Yeah, we see this from time to time. So occasionally there's a few things you can do. One is you can try to build up a vac lock such that it matches the patient's spinal curvature. This is difficult to do. Often you have to put things under the vac lock, which makes it a little bit less effective for immobilization. But we've had success in the past, kind of just modifying our vac lock bags to make them match the patient's contour a little bit better. We've also used some, like head immobilization and built that up really high and rotated it so that it's a little bit inclined to allow the patient's head to kind of be at the natural angle that their body creates, and then put a vac lock kind of tightly up against that and try to build it up to support the shoulders and the neck. It's very difficult. I think the standard mobilization tools that we have aren't well suited to that challenge. But really, it's working with the patient, taking a little bit more time at the simulation to try a few different things, and letting the patient tell you if it's comfortable and if they think they can hold that position for the amount of time it'll take to do treatment. Jose, I guess in your clinic, what do you do when you have patients with severe scoliosis?
Honestly, it depends. I mean, you may have to. I mean, it depends on what you're treating, right? But if it doesn't require very high immobilization, you can always use a thicker mat that may be more comfortable, and then then you're kind of giving up a little bit on your immobilization. But I mean, I've seen even sometimes treating patients on an incline, or I mean, it just depends on the situation. There is another question that is relevant to one of your slides here. This is Madiha. She wanted to know how reproducible is immobilization with the vacuum plastic on top of a patient.
It's pretty reproducible. The main thing is getting the patient on top of the vac-lock bag sort of in the like longitudinally in the right spot. So like the vac-lock will have this imprint of the patient, right? And if the patient is sort of longitudinally in the wrong spot, then like their posture can change, because maybe the depression created by their like upper thighs or their knees is now aligned with a different part of their legs or a different part of their back. And that can cause the posture to change, and that can make it difficult to align the patient. And so as long as you're really diligent about getting the patient on top of the vac-lock bag in the right spot, their posture should be pretty similar to simulation. And then everything you put on top more or less, does the same thing. One of the nice things about the plastic sheet is that it distributes pressure pretty evenly. So you don't have this like squishing of one part of the body to achieve compression. The downside of the plastic sheet is that like you have to get a good seal, and sometimes it's really difficult to get a good seal. And there's, our radiation therapists spend a lot of time like, messing with the plastic and like tucking it under a little bit more and trying to make the seal a little bit better to achieve the same level of pressure every day. That's really where the difficulty of these plastic sheet-based systems come in, is getting the same level of pressure on the patient every day.
Dustin, does it affect the amplitude of respiration for DCT? That's another question that is being asked.
Yeah, we've actually studied this quite a bit because we've had patients who've complained about the level of compression and like the tolerability of it, how comfortable it is. And so we did some studies to see like between like 80 psi and 60 psi and 50 psi, like how much does a 4D CT respiratory cycle change as a function of pressure? And we didn't see a big difference. It turns out that like a little bit of compression kind of gets you somewhere, and then like adding more on top of that doesn't change it very much. We're not sure where that threshold is, but even between like 50 and 80, we didn't see a huge difference in the amount of change in the respiratory cycle. So fortunately, I guess the respiratory, the size of the respiratory motion isn't super duper sensitive on the amount of compression with the plastic sheet.
Somebody was also asking if it would be possible to simulate somebody prone for these types of treatments.
Ooh, we've never done that before. Yeah, I can't think of a reason to do that, but the patients come in a lot of shapes and sizes. I suppose there's some application for that, but we've never done a thoracic patient in the prone position before.
Yeah, I think it would be a problem with respiratory mode. I mean, like the patient breathing and being comfortable.
Yeah.
And also you would have to come in from under the couch with your beam, so it might not be a good situation at all.
Yeah. All right. So there's a few things to consider with regard to image quality for lung radiotherapy. So CT artifacts might be present if a patient has an implanted medical device, so you can keep an eye out for that. The scan range is important for lung radiotherapy for a couple reasons. One, we use non-coplanar beams sometimes, and non-coplanar beams are going to be entering the patient higher and lower in the patient volume than coplanar beams, which strictly come from the side or the front. And so you need a little bit more scan range above and below the patient to ensure that the entirety of the beam entrance can be modeled through the patient through the imaging volume. In addition, we have the lungs in lung radiotherapy, and the lungs are parallel organs, which means they have DVH goals and constraints, mean dose goals and constraints, and you need the full lung volume contoured in order to calculate mean dose and DVH values. And so even if the tumor is confined to the upper half of the lung, you have to scan through the top of the lung and the bottom of the lung. Generally, we do 5 to 10 centimeters superior and inferior to the lungs themselves to make sure that we get the full length of the lungs in the scan. And we'll scan even sort of longer if we're going to be using non-coplanar entrance directions. Here's an example that happened in my clinic not too long ago. The radiation therapist accidentally terminated the scan volume just at the very bottom of the lungs. And so there's probably maybe a centimeter of really thin, narrow lung tissue missing from the lung volume here. So, ideally we would have scanned a little bit further, and we didn't. When this happens, you have to decide what to do. Ideally you would catch this at the simulator and simply scan again. This can be impractical if you've done a 4D CT and you need to do another 4D CT. 4D CTs, deliver quite a bit more radiation dose. than a typical CT. And so that simply adding on another 4D CT isn't always, the best thing for the patient. In this case, we kind of evaluated it. We thought, okay, this is a relatively small amount of lung that we're missing. We're treating disease that's higher up in the lung. So we're not, this cutoff region isn't affecting the dose distribution to the target. We ultimately decided to proceed and accept some of the uncertainty in the lung metrics, but it's really a case-by-case thing. And ideally, you have good protocols in place at CT to prevent this from happening altogether. So in addition, some other aspects of image quality to mention, field of view should include the shoulders and the arms. This can help you during treatment planning to see if there's going to be potential for collision. Slice thickness is an important consideration in all treatment planning, in particular for lung radiotherapy. Generally in our clinic, we use 3 millimeters or less for conventional radiotherapy and 2 millimeters or less for SBRT. And certainly if you have a really small target, if the tumor is 1 centimeter or less or 2 centimeters or less, it can be worthwhile to go to a smaller slice thickness. So often in our clinic, we'll go to 1 millimeters when we have a smaller lung radiotherapy target. And this helps us define the target more accurately. Slice thickness is all about having good quality images for target definition. And so you can really let your target size drive slice thickness, and generally trying to keep it 2 millimeters or less or 3 millimeters or less is good. 4D CT image quality is important, and we'll be talking about that in a few slides. With respect to variable anatomy, some lung radiotherapy patients can't tolerate the arms up position. It must be treated with one or both arms at their side. If this is required, it's important at this time to review the arm positioning and make sure you think it's reproducible. And again, arms tucked at the side in a mold is probably the best you can do in this particular scenario. Another consideration is that often lung radiotherapy patients have atelectasis or pleural effusions or some other fluid accumulation in their lungs. And this can evolve during treatment, both independent of the treatment or because of the treatment, and impact the target geometry as well as the attenuation of the treatment beams. This is a fairly dramatic example of a pleural effusion that one of our patients had. We simulated this patient, and this is what their right lung looked like. And when the patient came for their first fraction, the pleural effusion had been completely resolved. And so we had to resimulate them in order to continue with their plan of care, because the lung volume or the lung anatomy had changed so much. And it affected the position of the tumor and the configuration of the areas that we were treating. So we don't necessarily often use contrast for the lung tumor in lung radiotherapy, but we often treat mediastinal and hilar lymph nodes in lung radiotherapy, and IV contrast is really useful for the detection and contouring of these hilar lymph nodes. We've also been on some clinical trials here at the University of Wisconsin where they require IV contrast for lung radiotherapy, regardless of whether the mediastinum is being treated. And so we occasionally have patients who have had IV contrast. And one thing we need to consider is there enough IV contrast there that it will affect the accuracy of the dose calculation? One alternative to worrying about that is simply scanning the patient twice, once without contrast, and then again with contrast, and registering the two images. But if your treatment planning CT has contrast in it, you'll definitely want to consider a density override. And I'll be talking about density overrides in a little bit, and we'll have an example of that. Implanted electronic medical devices, really the best reference here is task group 203 from the AAPM. But some basic considerations, generally you want to avoid high energy photons for 15 MV, 18 MV, 21 MV when treating near implanted electronic medical devices. This is generally not an issue for lung radiotherapy because generally we treat with 6 MV in the lung almost exclusively because it's better for depositing dose in low density areas, which the lungs are a very low density area. So primarily for lung radiotherapy, we concern ourselves with minimizing dose to a cardiac device and trying to avoid direct irradiation if we can. If a device is really close to the target volume, which sometimes happens, you can ask a cardiologist to move the device. Sometimes they will, sometimes they'll refuse. If you can't move the device, then it's likely that the device will receive, higher radiation than you would like, maybe some direct irradiation that might affect its function. You have to work closely with your radiation oncologist and your cardiac device nurses and your cardiac device physicians to make sure the patient's treatment is managed safely. And Task Group 203 has a lot of really great advice about how to do that. Lastly, image selection for radiotherapy of the lung is usually pretty simple, except that sometimes at simulation, the physician won't know if they want to do a 4D CT with compression and treat during free breathing, or a breath hold treatment, and they may ask you to do both. And then they'll look at both and decide based on, the images, which way they want to treat. And so occasionally you'll have both kinds of simulations. And you'll have to make sure you select the correct kind of simulation for your planning scan that is consistent with the physician's intent. In addition, if you have a 4D CT, you usually have, the phased images. You might have a maximum intensity projection image. You want to make sure that you're using the 4D CT average scan and not one of the phase images and not one of the maximum intensity projection images for planning. So it's good to check that the right image was selected for the treatment plan. All right, here is our first Zoom poll. Why is it not appropriate to use photon beams with energies greater than 10 MV when treating a patient with a pacemaker or ICD? This is something that's been, I think, discussed in almost all of the talks so far. And so it's a good opportunity to review. And I kind of mentioned it in passing, but it's a great opportunity to think about this particular safety consideration that is quite relevant to lung radiotherapy.
Make sure you're participating in the poll if you can. And don't be afraid, nobody knows what you answered. So we have about half of participants who have answered already. So I'm gonna end the poll. And here are the results. Can you see them on the screen?
Wonderful, yeah. So it looks like the top choice was pacemakers and ICDs are sensitive to, which are generated by high energy photons, and that is correct. I do think number 4, which is the second most common answer, there's absolutely some truth to that. Pacemakers and ICDs aren't modeled well by a lot of treatment planning systems, and dose calculations are much less accurate. In general, we try to avoid them entirely to mitigate that issue, but sometimes you do end up having to directly irradiate them. And certainly there's big dosimetric uncertainty to pacemakers and ICDs, which is why a lot of times we'll do in vivo dosimetry. All right, great work, everyone. Let's keep going here. So particularly important to lung radiotherapy is motion management. And there's some good guidance out there on, when you should consider performing motion management and kind of different degrees of motion management as a function of tumor motion. So APM TG76 is a task group on motion management, and their recommendation is to consider motion management if the target motion is greater than 5 millimeters. And then I'll be talking about NRG a little bit during this talk. NRG is a clinical trial organization, and they often, in addition to running clinical trials, they produce a lot of really great resources for how to perform high quality radiation therapy. And I think their lung radiotherapy resources are really good. So I'll be sharing some of them during this talk. Per this NRG group, abdominal compression is recommended in cases where the extent of motion exceeds 10 millimeters or 1 centimeter for the primary tumor and nodes. And they recommend considering it more generally if the motion exceeds 5 millimeters, but certainly 10 millimeters is a nice threshold. In my clinic, if motion exceeds 10 millimeters in the presence of compression, we'll switch to a breath hold treatment instead of having the patient being treated free breathing. And so we kind of have this like above 5 millimeters, use compression plus 4D CT, and then above 10 millimeters, we'll go to a breath hold treatment. I think the best thing you can do is just have institutional guidelines for your own clinic for what you're going to do, and just have a plan so that for any given patient, you have a basic idea of what you want to do based on the amount of motion. This is a table that I've adapted from a document called NRG Protocol Radiation Therapy Section Template. You can find this on the NRG website. I have a link for this on a later slide. I apologize that I don't have the link here, but it's a summary of the different motion management strategies that are recommended for patients on NRG clinical trials. And there's basically 4 broad techniques. There's free breathing with a 40, capturing a 4D CT, contouring the extent of tumor motion, and then treating the full motion envelope plus a PTV. We often call this an ITV approach. The NRG group calls an ITV an IGTV, so there's a little bit different terminology. But in addition, you can gate treatment, so a patient can be treated free breathing, and you can gate the beam when they're outside of a certain area of the respiratory cycle. I don't have any familiarity with this technique myself, but there's a great paper on this in the Journal of Applied Clinical Medical Physics that I have here, which is a really great reference if you're interested in learning more about gating. Of course, breath hold is an alternative to having the patient being treated free breathing. And lastly, there's tumor tracking, which commercially is not very common. There's some clinics that are doing this from a research perspective, and there's a few clinical systems like CyberKnife that allow you to track during real time. But by and large, I think most clinics are using free breathing and an ITV approach for breath hold for motion management. And like I said, this table is in this energy protocol document. So if you're interested in learning more, this table actually has a few more columns, but I kind of cut it out to simplify it a little bit. So just a quick aside on abdominal compression. There's a couple different methods for abdominal compression. You can have a plate over the patient's abdomen that can be tightened to exert mechanical pressure on the patient's abdomen. This will induce shallower breathing and reduces internal respiratory motion. There's also things like a belt that you can place over the patient's abdomen and then fill with air to compress the patient's abdomen. And then finally, we talked about the plastic sheet covering a full body mold with a vacuum suction. And then there's this white pillow on top of the patient's abdomen and on top of their chest. And this is just a way to distribute the pressure more uniformly across the patient's surface. And so all of these are ways to perform abdominal compression. The main benefit is that by compressing the abdomen, you reduce the amount of respiratory motion, which is desirable for reducing the amount of the irradiated volume or the target volume in the patient. But there are drawbacks. Of course, abdominal compression is uncomfortable for patients. Some patients can't tolerate it. Some patients can only tolerate it for a short period of time, which may restrict the kinds of planning techniques you can use. In addition, methods that use local compression, like the belt and the plate, can result in day-to-day variations in positions of abdominal organs because of the way that the chest is being compressed. This is less a consideration for lung radiotherapy, but if you are doing abdominal radiotherapy, you can see differences in lung anatomy day to day with these compression techniques. So lastly, here in motion management, we'll talk about the 4D CT scan accuracy. So it's important to evaluate your 4D CT to make sure that you have a high quality set of images for making decisions about where the target is on different phases. Justin had a really great discussion on this during his SBRT SRS talk. Generally, if you're looking for artifacts, looking at the diaphragm is a great place to look. If you see that kind of like cup moving up and down, that's a sign that perhaps the patient's breathing wasn't very regular during the scan, and the patient might benefit from a resimulation, or at least you should take a closer look at the accuracy of the data you're using to decide the extent of target motion. If the 4D CT is heavily affected by artifacts, resimulation is the best option because it's the only way to get the true respiratory cycle measured in the patient.
Dustin, there's a question. In the case the 4D CT and the average mid-sequence is poor quality, can we use another sequence and to check ITV in others? Yeah,
the 4D CT is the gold standard. And so getting a high quality 4D CT is really the main goal. If a patient doesn't breathe regularly and you just can't make it happen, one possibility is switching to breath hold. That's often what we do in our clinic if the patient isn't breathing regularly. If you don't have breath hold commissioned in your clinic, then it's a little tricky. You can do things like add additional margin to your target volume to account for some uncertainty in the respiratory cycle that you've measured for the tumor. Yeah, it's tricky when you can't get a good 4D CT. Your options aren't very good in terms of determining the patient's respiratory motion. Quick aside on pitch for 4D CT. So the pitch for a 4D CT must be selected such that there is at least one full respiratory cycle scanned at each couch position, so that in any given part of the patient, you're scanning the full respiratory cycle and getting a full picture of that motion. And there's a nice little equation for determining the maximum pitch that will allow you to achieve this. And it's this TG divided by TB plus TG. And TB is the patient's breathing cycle, so the breathing period in seconds, and TG is the gantry period in seconds. For many scanners, this is about 0.5 seconds, but scanner technology is always changing, and so TG can be different for different scanners. And faster or slower depending on the design of the scanner. So for example, if the patient's breathing period is 4 seconds, that's 15 breaths per minute, and the gantry period is 5 seconds, the maximum pitch needs to be 0.11. As scanner technology has changed, the way that you enter this information has changed over time. So some vendors provide tables to help you convert the breathing period to a pitch, and then you have to manually enter that pitch correctly on the CT scanner. Other vendors may ask you what the patient's respiration rate is or what their breathing period is, and then it will automatically select a pitch based on that information. So it depends on the scanner and how their software is configured. But it's good to know this about your own scanner and understand exactly how to select the correct pitch for a 4D CT. All right, let's pivot to treatment planning. So for lung radiotherapy, image registration is really important and also kind of tricky. The lungs are highly deformable organs, right? And so even two 4D CTs taken 6 months apart can, the lungs can look like different size, things can like rotate a little bit. If you have prior RT, that can cause a change in the internal shape of the lungs and the stretchiness of certain parts of the lungs. And that means that registering, patient anatomy all over the thorax is almost always impossible. Generally, you have to pick certain areas to focus on and try to maximize the registration accuracy in that area. So a couple examples here. Let's say you have a PET scan that shows uptake in both the lung and the mediastinum. Both sites probably can't be registered accurately between the PET scan and the treatment planning scan. And so the best thing you'll be able to do is to create one registration for the lung, one registration for the mediastinum, and use both of those separately to do contouring. If you have a patient who has multiple courses of radiotherapy, and the physician is interested in the dose to the spinal cord and the dose to the new tumor volume, you'll probably need 2 registrations, one on the spinal cord, one on the new tumor volume, to be able to do dose summations in a way that will let you know the true dose to the patient in those 2 locations. Here's a quick clinical example where we have a patient who had a course of radiotherapy to the upper lung and then a second course of radiotherapy to the upper lung. And you can see these, oh shoot, I was hoping this video would repeat itself. Let me see if I can get it to play again. Maybe I'll just do it manually with my mouse here. So you can see that one was done on a breath hold scan. Here's the breath hold. One was done on a 4D CT. And so of course the lungs can't be perfectly registered here because the breath hold scan has a much larger lung volume than the 4D CT volume. In this case, we wanted to know if there is dosimetric overlap between the 2 plans. And so we focused our fusion on the area around the 2 target volumes and more or less ignored the rest of the lungs. And that let us achieve our goal of answering the specific question of whether there is dose overlap between the 2 volumes. All right, let's talk about contouring. I want to just point out this atlas for organs at risks in thoracic radiation therapy. This is from the NRG Oncology Group. And here's a link to the page that will get you to not only this PowerPoint presentation, but also some other resources about treatment planning for lung radiotherapy. It's a really nice website for that use. So if you're doing a 4D CT and you're targeting based on all the phases of the respiratory cycle, then you have to generate an ITV or an internal target volume. The ideal way to generate an internal target volume is to take a union of the GTV on all of the phases of the 4D CT. So your inspiration, your expiration, all phases in between, determine where the GTV is on each phase, and then cover that area as your ITV. An alternative is that you can define the GTV on a maximum intensity projection image. If you do this, it's really important to look at the phases individually and make sure you didn't miss anything, because sometimes the maximum intensity projection doesn't make it obvious where the tumor is on all phases. And a MIP is not appropriate for tumors located near boundaries with soft tissue, such as near the diaphragm or mediastinum. And Justin provided a nice example for me. Here we have a lung tumor that is, kind of touching the mediastinum, and it can be really difficult in this scenario to know exactly where does the tumor end and the diaphragm begin. And so when you're in a situation like this, it's really valuable to look at the individual phases and to define the GTV on those individual phases, rather than trying to guess where the target ends on a maximum intensity projection image when it's bumping up against the diaphragm. I want to just touch on naming conventions for internal target volumes. When ICRU 62 first introduced the concept of an ITV, The assumption was that you would always have a GTV and you would expand it to an ITV, and then that ITV would get expanded to a PTV. But as this technique for SBRT started to be used more in conventional radiotherapy, where we have GTVs and CTVs and PTVs, sort of by convention, we needed to introduce this concept of a CTV based ITV, and the NRG clinical trial group introduced some new terminology. So there's IGTV for internal gross target volume and ICTV for internal clinical target volume. And often when you're looking at lung radiotherapy planning, you'll see these two terms instead of ITV. And I just wanted to point that out because it can be a little confusing, like what's the ITV versus the IGTV? All these concepts are very similar, but there are some nuances that are important to know. So the IGTV is basically the ITV. It's this gross tumor volume on all phases. When you normally would expand a GTV to a CTV to account for microscopic disease, that becomes the ICTV. And sometimes you'll modify the ICTV to not expand into the heart or esophagus or blood vessels, just like you would in regular CTV, avoid expanding into areas where the disease is very unlikely to be expanding. Then a PTV, of course, is uniform expansion of the ICTV. So I just want to note these names and concepts, since you'll probably see them in literature. And of course, if you review those NRG documents, you'll see them in there as well. With respect to target and OAR accuracy, for conventional lung radiotherapy, targets may include the primary lung disease as well as nodal targets. Organs at risk generally include the brachial plexus, esophagus, heart, healthy lung, skin, and spinal cord. For lung SBRT, you're typically looking at one or more small lung lesions and not treating the mediastinum. In addition to the organs at risk for conventional lung SBRT contours will often include the chest wall or ribs, the great vessels like the aorta and the proximal bronchus and trachea. So additional organs at risk in the mediastinum will be included in lung SBRT planning. There's also this normal 2 centimeter, which is the external minus the PTV plus 2 centimeters. So this is basically all the normal tissue more than 2 centimeters away from the PTV. And this is often used to drive dose fall off for lung SBRT. In addition, for both conventional and lung SBRT, you'll want to pay attention to the stomach, liver, and bowel for any targets that are close to the abdomen, since these organs at risk can overlap with the PTV if you have lung disease that touches the diaphragm. In terms of contour quality, I just wanted to mention for lung, typical missing OARs are the organs at risk that are kind of at the periphery of the lungs. So the brachial plexus can be easy to forget. We don't always contour it unless the target volume is close to the brachial plexus. We don't always contour it because it's a very intricate and difficult structure to contour. And so if you don't need to do it, it's nice to save time and not contour it. But if you forget, that can be really dangerous to the patient. And again, anything in the abdomen that's close to the thorax, stomach, small and large bowel, liver, these can be missing in cases where you're treating close to those organs at risk. So here's another clinical example. We have a patient here being treated with non-small cell lung cancer of the mediastinum and right lung. So you can see there's kind of two separate lung volumes. The physician drew ITVs for the lung, ITV for the mediastinal nodes, and then created a PTV just that encompassed both of them. And this is sort of like what they presented to the dosimetrist for planning. Later on, the physician decided that actually I want the lung tumor to get 60 gray and I want the mediastinal nodes to get 66 gray. So actually, he didn't want one PTV. He wanted two separate PTVs with two different doses. So the dosimetrist created new PTVs by essentially copying this PTV and then erasing one of them, and then copying it again and erasing the other one. And this is just kind of an opportunity for manual error, right? Like it's really difficult to actually use the eraser tool and erase every last pixel in a contour manually. And that's what happened. So a little bit of one PTV got left behind in the other PTV when this manual erasing process happened. So the best way to solve this is not to do this erasing thing. Just start with your ITV and do a PTV expansion separately for each one. That avoids any sort of manual error that might happen. But this is a case where some stray voxels got left behind and caused some issues during optimization. And luckily we spotted this and were able to solve it. All right, so for margins, for PTV margins in lung radiotherapy, it depends a little bit on the technique you're using. If you're using a 4D CT and an ITV approach, which is the most common lung radiotherapy treatment that we have in our clinic, we usually use a 5 mm uniform expansion around the ITV. This is generally what's recommended in clinical trials. This has been used for a very long time. I would say it's probably the most common margin used for lung radiotherapy planning. If you're doing deep inspiration breath hold, often your margin size will be a little bit larger to account for some variability in the breath hold. There's different ways to account for that. Some clinics will scan the patient multiple times, contour the GTV on all of those images, and expand that by a certain amount, like 5 mm or 6 mm. Some clinics will use a more complex set of conditions to determine the margin size, like, is it located near the heart? Okay, let's make it a little bit bigger to account for cardiac motion. Oh, if we take multiple scans and there's lots of variability in the position, maybe we should make it a little bit bigger to account for additional variability. So different clinics will use different approaches there. But generally, drawing an ITV, even for like a breath hold treatment where you have multiple scans to determine the range of possible positions for the target in breath hold is a good way to do it. One consideration for conventional lung is if a patient has atelectasis or some other issue with their lung causing, like high density regions of the lung tissue, you want to ensure that there's additional margin to account for changes in lung that might happen during treatment delivery. Generally, you'll want to replan if there's a really big change, but often you can't replan immediately. So it's good to have a little bit of extra margin in the event that there's some change so that you have a little bit of time to replan. You don't have to stop the patient's treatment.
Dustin, there's a question about the margin. It says,
Yeah.
do you consider CTV margin for lung SBRT?
Generally, the GTV is equal to the CTV for lung radiotherapy. Sorry, for SBRT. So, in our clinic, we have the ITV and we have the PTV. We could make a CTV, but the CTV would just be equal to the ITV. So by convention in lung SBRT, the CTV is the ITV. Or you might say that the CTV is a 0 mm expansion of the ITV. And that's different from conventional lung, where you often have a 5 mm expansion of the GTV or ITV to get your CTV. Speaking of that, the next example involves ITVs, CTVs, and PTVs. So we have a patient being treated for non-small cell lung cancer of the left lung. Here we can see some physician-drawn contours, in this case, a resident drew some contours, purple ITV, orange CTV, red PTV, and then performed standard 5 mm expansions. A little later on, the attending physician came along and updated the ITV, and then got distracted and forgot to expand the CTV and PTV. And so during the planning process, a dosimetrist discovered that the ITV was outside of the PTV in certain locations and questioned it appropriately. And then, luckily, we discovered this before the patient was planned. The attending physician updated the CTV and PTV, and we were able to continue planning. But this is an example of how these structures really are like codependent on one another, and it's really important to make sure that if you make any modifications to the lower level contours like the ITV, those get accounted for in the CTV and PTV later on. With regard to external contour and support structures, I don't have a lot to say on this. This is for lung radiotherapy, fairly similar to other types of treatments. You want the external to include the entire patient, their arms, as well as any immobilization devices that cause significant attenuation. In my clinic, the immobilization devices we have don't cause significant attenuation, and so we don't generally include them in the external. But depending on what you have in your clinic, you may have to do that. So it's important to keep in mind. There's generally two reasons to do density overrides in lung radiotherapy. One is if contrast is administered and is, really accumulating a lot in certain organs like the heart. In addition, if you have an implanted device, there's usually scatter artifact and photon starvation artifacts. That's where like the image gets really dark around a high Z material, and those need to be corrected by performing a density override. One question you can ask is a density override required? So, blood is typically 1 gram per cubic centimeter. On this contrast CT, we can see that the heart is a little bit brighter than you would expect because it's full of contrast. In this case, it has an HU value of 129, which in my clinic was roughly 1.1 grams per cubic centimeter. Across this thick aspect here, the heart is 18 centimeters across. If you account for the water equivalent thickness because of the higher density on the CT scan, you'd imagine that the water equivalent thickness would be, 20.2 centimeters. But really, when the patient is treated, there isn't any contrast in their heart. And so the real water equivalent thickness during treatment will be that 18.3 centimeters. So the difference is about 2 centimeters, and that's going to cause an attenuation change of about 6%, which is quite a bit. That's a big error in dose calculation. And so overriding the heart to 1 gram per cubic centimeter is a really important thing to do if you're planning in this region. In contrast, the aorta is much less thick. And although the density is sort of wrong by the same amount, because it's less thick, the impact is smaller, only about 1%. If you've contoured the aorta, you can probably override it. But in this case, a 1% error is probably tolerable from a dose calculation standpoint, particularly if you're doing rotational therapy and you're only delivering dose through the aorta part of the time. But this is kind of a quick way to assess whether a density override is needed. Often it's not, except for the heart. Okay, here's our second Zoom poll. In lung radiotherapy planning, how do you define the internal gross target volume?
All right, and you have the poll on your screen right now. So go ahead and make your choices. And we're getting close to about half of the participants answering. Just give it a couple more seconds. All right, I'm going to end the poll here because it's pretty even. And here are the results.
Excellent. Yes, the first answer is correct. The ideal way to define the IGTV is the full motion envelope on 4D CT of the GTV over the course of a respiratory cycle. You can also use the MIP, as we discussed. You don't want to use that near the diaphragm or the mediastinum, but the ideal way is to use the phases of the 4D CT. All right, let's transition to talking about beam arrangements. First, considering treatment technique, 3D, IMRT, VMAT, SBRT. Most conventional lung radiotherapy is treated with IMRT and VMAT, and most SBRT is also treated with IMRT, VMAT, or occasionally dynamic conformal arcs, which, when you have a really, really small lung SBRT target, very often when you commission your IMRT and VMAT dose calculation, you'll have stopped at some target size, right? In my clinic, we generally commission our VMAT algorithm down to targets that are 2 centimeters and larger. And so below 2 centimeters, we don't have a lot of confidence in our dose calculation algorithm for VMAT. And typically below 2 centimeters, we change our planning technique to 3D conformal arcs because we've commissioned those down to 1 centimeter or 5 millimeters, depending on our treatment planning system and our model. So it's good to keep in mind the target size will impact the treatment technique. And you may have a lower limit on IMRT and VMAT dose calculation accuracy that will affect when and where those techniques can be used. So I shouldn't say unique to lung radiotherapy, but it's very common in lung radiotherapy that you have a target volume that is confined to one lung and the opposite side of the body doesn't have any disease. And you have this lung on the other side of the body that's really important. You want to protect it as much as possible. So you're highly incentivized in lung radiotherapy to use either a partial IMRT beam arrangement that doesn't enter through the contralateral lung or partial arcs that don't enter through the contralateral side of the patient. There's a couple of reasons to do this. One is that if you have your isocenter in the target is lateral in one of the lungs, then the treatment table will be shifted over quite a bit to put that target at isocenter. And so having partial arcs reduces the likelihood of having a gantry table collision on the contralateral side of the patient. But of course, not entering through the contralateral lung reduces contralateral lung dose and improves the dose to that organ. We find that using 2 partial arcs is typically sufficient for both conventional and lung SBRT planning, although we'll occasionally add a 3rd arc or some non-coplanar beams during planning if we need some additional degrees of freedom in the optimization or we want to avoid a certain organ at risk. So I'll show some examples, but short arcs at non-zero couch angles like 15 degrees and 95 degrees can help improve dose fall off as well, particularly for lung SBRT. So when I was making this talk, I polled the rest of our group on what does your clinic do for lung radiotherapy? Do you primarily use coplanar arcs and beams, or do you mix in non-coplanar arcs and beams with couch kicks? What I learned is most of us are planning most of our lung radiotherapy patients with coplanar beam arrangements only. I apologize, this should say non-coplanar beam arrangement. I think it'll be clear from the text. So 2 to 3 coplanar arcs, full arcs for central targets, partial arcs for lateral targets. The benefit, of course, is you reduce the likelihood of collisions. It's also more efficient because kicking the couch takes time. You might have to do additional clearance checks. So avoiding the use of non-coplanar beams can be a little bit more efficient. The drawback, of course, is that the dose gradient in the AP and right-left directions will be shallower compared to plans with non-coplanar beams. Typical non-coplanar beam arrangements from physicists who are putting this webinar series together include typically like a normal set of coplanar arcs plus some non-coplanar arcs that are added in. So maybe one at 15 degrees and one at 90 degrees that only comes in anteriorly. One clinic used 2 non-coplanar arcs that are like plus or minus 15 degrees away from couch zero. And again, the benefits are sort of the opposite of the drawbacks of coplanar arrangements. So better dose gradients. You have better dose fall off when you use non-coplanar beams, but you have additional deliverability concerns. Increased likelihood of collisions or clearance issues with the patient. The plans will take a little longer to deliver. This might be important for patients who are taking a breath hold, who, the longer they're on the table, the more tired they can become. And of course, we run into this issue where our respiratory gating camera can't see the box on the patient if we kick the couch more than 45 degrees. And so we try to avoid non-coplanar beam arrangements when we're doing a breath hold treatment because of some technology issues that we have. These are the beam arrangements that we use for lung radiotherapy in our clinic. You can see kind of a table of examples on the side. And on the right, we have an example of a patient who has 2 coplanar arcs and then a non-coplanar anterior 15-degree arc and an anterior arc with a couch peak of 90 degrees. It's basically coming straight down the front. You can see this patient's elbows are pretty forward. This patient couldn't bend their arms particularly well, and so we had to terminate this anterior arc at 90 degrees somewhat short because we didn't want to bump into the patient's elbows. Let's talk about beam deliverability. We've talked about this a little bit already in terms of gantry table collisions. So using partial arcs can help avoid collisions. You'll see an example coming up where a dosimetrist placed an isocenter outside of the target volume to improve the deliverability by placing it in a location that was less likely to cause a collision. And one of the most challenging things with lung radiotherapy is that the gantry might collide with the patient's elbows. Very often, the full extent of the elbows isn't in our CT scan, so it can be really difficult to predict clearance and collisions ahead of time because we don't have a full map of the patient's surface or their anatomy in the treatment planning system. There's some technology coming out that allows this, but most clinics don't have it. My clinic doesn't have it, and so often we have to kind of just play it safe and do dry runs or clearance checks before treatment to make sure that the elbows are out of the way. So here's an example. We have a patient who is being treated with lung SBRT. The target volume is very posterior and the patient had poor mobility. So they're simulated, with their hands on their head, elbows up. You can see it over here on the right. The elbows are pretty lateral. They're not really going superiorly. They're pretty lateral, kind of at a 45-degree angle. And then during a pre-treatment dry run, the radiation therapist determined that the gantry would bump into the patient's elbows. Fortunately, we had to stop and replan this case. And we did so by shifting the isocenter 10 centimeters anteriorly. If I kind of flicker back and forth, you can see that the patient is moving up and down relative to the gantry. So basically by moving isocenter, we created more distance between the patient's arms and the gantry. And this allowed us to create a plan that would clear and allow us to treat the disease. Let's talk about robustness. Primarily with robustness, the main consideration is arm positioning. If the patient's arms are down, you really want to assess the impact of arm positioning on the dose delivery. Hopefully you don't have to do this, but every once in a while you'll have a case perhaps where you have to treat through the arms. Another consideration too is if you're treating more than one target, again, the lungs are very deformable. And so depending on the patient's lung volume and posture, the lungs might be more stretched out or less stretched out each day of treatment. And aligning multiple targets in the lung simultaneously can be really difficult. My clinic has a rule of thumb that multiple isocenters must be used when targets are separated by more than 7 centimeters. This was based on some internal studies that we did to try to figure out, at what distance apart the targets start to spread out more and become more difficult to co-align. And you'll want to kind of look at your own center and your own patients to see what this size is going to be. So here's kind of an extreme example of, this is in the lung cancer patient. This is a chondrosarcoma of the left hip joint that metastasized to the right lung. We have 10 lesions that are really closely spaced in the lower left lung. So you can see here, they're basically kind of just like on top of the diaphragm in a very narrow range of the lung, all very close together. 2 of them are a little bit anterior though. You can see they're up front here. And one of the challenges we had is we tried to apply our 7-centimeter rule here. And when we did, we ended up with 4 isocenters. But it's really challenging to plan 4 plans with different isocenters simultaneously in a way that allows you to manage the low dose spillage among plans. So on the bottom here, we have our 4 isocenters plan, and it looks really bad. There's like a lot of like 50% isodose everywhere. The target volumes aren't covered very well. We tried to use some co-optimization tools in RayStation. They didn't work very well for this case. When we planned them all with a single isocenter, we got a much better plan. But then at the treatment unit, we had a really difficult time setting this patient up. So there is no solution to this, I would say. There's just some trade-offs that you have to consider. More isocenters makes it easier to align patients to treatment, but fewer isocenters makes it easier to make a plan, and you have to find the happy medium between those. This is a very, I think, extreme case. We don't see these very often, and so, fortunately, we don't have to contend with this that often, but it is something that happens from time to time, and we're still trying to figure out the best way to treat these cases. So beam energy for lung, we're primarily using 6 MV for conventional radiotherapy and 6 flattening filter free for SBRT. Flattening filter free is especially good for SBRT because these treatments have more monitor units and take longer to deliver. So flattening filter free modes just have a faster dose delivery that allows the patient's treatment to be conducted more quickly. So if you're using compression and they're uncomfortable, treatment is faster. If you're doing breath hold and the patient is uncomfortable, that allows you to deliver the treatment in fewer breath holds and there'll be less drift during treatment. So faster is better for lung radiotherapy. Generally speaking, for lung radiotherapy, collimator angles, the rules in general for VMAT that you should vary collimator angles for different arcs, apply equally well here. One caveat is if you're treating multiple targets in the same isocenter, like you see down here, it's good to have the collimator turned, at least for some of the arcs, so that the area in between can be blocked by the MLCs. That will allow you to get good dose fall off between the targets. When evaluating the beams I view for lung radiotherapy, generally, the rules that apply to VMAT or planning in general apply to lung radiotherapy. But again, if you're treating more than one ISO, you want to make sure, like on that last slide, that leaves are closing between targets so that you have good dose fall off between targets. We have 2 vastly different planning techniques in the lung. We have conventional versus SBRT, and the block margins are going to be a little bit different. And so for lung radiotherapy, you want larger block margins around the PTV. Typically 5 to 8 millimeters are used for conventional lung. Sometimes in conventional lung, we need a little bit larger because the target is in lung. And so the electrons in the beam are actually traveling further and the penumbra is a little bit wider. And so a larger block margin will allow you to have better coverage of the target volume further away from near the edges of the target. In lung SBRT, we use really tight block margins to drive fast dose fall off and put a big hot spot in the middle of the target. So block margins of 2 millimeters or less is typical for lung SBRT. And if you're doing IMRT and VMAT, many planning systems have tools that allow you to restrict the aperture shapes to a certain distance from the PTV. In RayStation, this is called treat margins. I know Eclipse has this concept. I don't remember what the name of it is, but it is an option in the optimizer to restrict the aperture size so that the shapes created during optimization won't open up too far away from the target volume. Dose rate, we kind of already went over this concept of dose rate, but typically we're using the maximum dose rate during planning. So usually that's like 600 monitor units per minute for conventional radiotherapy, and then whatever the maximum dose rate is for your flattening filter free mode for the use of FFF beams. FFF is really great for breath hold treatments and phase gated treatments because these treatments have lower duty cycles, meaning that the beam is on a lower percentage of the time during treatment when the patient is in the room because you are gating the beam, match certain parts of the breath hold cycle. So higher dose rates keep the treatment time shorter. That improves patients' comfort, that decreases the likelihood that the patient's breathing will drift over the course of treatment, which might require additional imaging on treatment. And so faster treatment delivery It helps the patient feel more comfortable and improve the accuracy. This is kind of an interesting example where a patient was being treated to a highly lateral lung lesion, and the dosimetrist mistakenly believed that flattening filter-free modes couldn't be used for off-axis targets and planned the case with 6 MV. And of course, this vastly reduced the dose rate for this particular treatment. And this was caught during physics review, and the case was replanned with 6 FFF, and the plan quality was pretty much unchanged. All of the objectives were met. The dosimetric objectives were pretty similar. If anything, they were maybe a little bit better with the FFF plan. But overall, the target coverage was about the same. And so this is an example where a dosimetrist kind of misunderstood the rules about planning, and we were able to correct that. Modulation factor, of course, is the number of monitor units in the plan divided by the prescribed dose in centigrade. Typically, what we see in our clinic is that the modulation factor is less than 4 for lung. I have some plots showing this. This is modulation factors for many different treatment sites. And you can see for conventional radiotherapy, the third quartile is roughly 3.5. So most of our patients, about 75%, have modulation factors less than 3.5. For lung SBRT, it's pretty similar. There are some, edge cases that go to 5 or 6. Some of these are probably multi-isocenter treatments, so probably more monitor units to deliver to multiple targets. But for the most part, it's like 3.5 or less. Lastly, beam modifiers like wedges, we generally don't use these for definitive lung radiotherapy. We'll talk about this a little bit more in the palliative care lecture in a few weeks, but not generally relevant to the use of radiation therapy for conventional definitive lung radiotherapy and SBRT. That brings us to our third Zoom poll.
All right, and the poll is on the screen right now.
Sorry? I see it, yeah. Which of the following factors does not influence the selection of photon beam energy during treatment planning?
All right, so we have about half of participants that have already responded. So I'm gonna end the poll here. I'm gonna share the results.
Wonderful. Yes, prescribed dose per fraction is the correct answer. Generally the size of the patient, has a small effect on the energy selection. Most often, in my clinic, energy selection is driven primarily by body site. So we generally use 6 MV for the head and neck, thorax, and any extremities. And then the abdomen and pelvis will use 10 MV or 10 MV FFF. But certainly the depth of the target volume can impact that. If it's primarily shallow, you definitely benefit from lower energy photons to protect tissue at depth. And of course, density of the surrounding medium is really important for lung. Using 10 and 15 MV in the lung is challenging because you have a much slower buildup of the dose distribution when you go from lung back into tumor volume. That can result in the lung target volume being a little bit cold near the surface. And so lower energy photons help minimize the effect of rebuild up or having a loss of equilibrium in the lung and the reestablishment of electronic equilibrium in the target volume. That happens faster for 6 MV, so we try to use that in the lung. All right, let's talk about optimization objectives. I'm going to go through these slides somewhat quickly, and then I'll have some examples on the back end to illustrate some of the techniques that we're going to talk about. When talking about target objectives, the main consideration is, what is the desired dose distribution that you want? Do you want a heterogeneous dose distribution, meaning a hot spot in the middle and prescription dose at the edges, like for SBRT? Or do you want a homogeneous or uniform dose distribution for conventionally fractionated treatment? And this is going to affect the way you optimize your target volume. Generally, your minimum dose will be pretty similar. You want that to be the prescription dose. But for conventional, you want your maximum dose to be relatively close to the prescription dose. And for SBRT, it's going to be much higher than the prescription dose because you want that hot spot in the middle. For organ at risk objectives, it's important to consider that, particularly missing objectives, you want abdominal organs to be included in the optimizer if appropriate. Again, you're most likely to forget about abdominal organs during contouring, and you're most likely to forget about them again during the optimization phase because we don't always have them in play as part of lung radiotherapy. But when we do, we want to make sure that we're protecting them as much as possible. Lung radiotherapy often involves conflicting objectives because the PTV and organs at risk are often overlapping in lung radiotherapy. In conventional lung radiotherapy, you'll often have the PTV overlapping with the esophagus or heart or brachial plexus or bronchus. This can lead to conflicts in the optimization because the objectives may overlap with one another. In lung SBRT, it's fairly typical to have lung adjacent structures like the chest wall, ribs, bronchial tree, great vessels overlap with the target volume. And again, that will create some conflicts that need to be resolved. And finally, we generally try to have a uniform dose fall off in all radiotherapy planning, and lung radiotherapy is no different. But if you have organs at risk nearby that require protection, sometimes you have to have dose fall off happen faster in a particular direction in order to meet those objectives. And so you might not have uniform dose fall off. And that might be okay. It really depends on the context. And so we'll look at a few examples of that. So here's an example of a target volume. We have a SBRT PTV overlapping with the chest wall. And what we've done here for planning is we've divided the target into something called an OTV, which in my clinic stands for optimization target volume. And this includes the target more than 2 centimeters away from the organ at risk. Then we have a PTV2 easy, and easy is just easy, as in go easy on it. Don't give too much dose to this area. That includes the overlap between the PTV and the organ at risk. And what we've done down here is really partitioned exactly what we want to do in the optimization. So the chest wall, we say, keep the maximum dose less than 57 gray. Our constraint is 57.5 gray, so we're aiming a little bit lower than that. The OTV is being told, hey, try to get 61.5 gray or more, so a little bit more than the prescription dose, and then a max dose of 78 gray. And then the PTV easy, we want a minimum dose of 52 gray, and we haven't really constrained the maximum dose, but the maximum dose is going to get constrained primarily by the chest wall objective. And in the final plan, you can see we more or less did exactly what we wanted to do. We kept the chest wall to less than 57.5 gray. We got a lot of dose to the OTV on the right side of the target volume. And then that PTV easy, got as much dose as possible while respecting the chest wall constraint. And then in between, we have this region where there wasn't any optimization, and there's just sort of a natural gradient in between. So this 2 millimeter region is basically there to allow dose to transition from one tier to another. Here's an example where we have a conventional lung radiotherapy target overlapping with the esophagus. And you can see here we created an OTV that excludes the esophagus and its planning at risk volume. So this is a 5 millimeter expansion of the esophagus. And then we have a PTV easy that's overlapping with the esophagus itself. We have some goals associated with the esophagus to limit the maximum dose to less than 63 gray. And the physician tells us we have to undercover to meet the 63 gray goal. We have an optimization target volume that's getting as much dose as possible. So trying to get the full 66 as uniform as possible. And this PTV, this PTV easy has a really light goal on it, trying to get 66 gray. But the weight is much less than the esophagus goals. And so the esophagus goals are going to dominate. But this will ensure that there's at least some dose that's going to get to this region that's overlapping with the esophagus. You can see here that it's getting roughly 60 gray, so a dose that's safe for the esophagus, but not the full 63 that would result in exceeding the physician's goal. And then the rest of the target volume is getting the full 66 gray here. And again, you can see these two separate DVHs where the OTV is getting almost a uniform 66, and the PTV easy is getting something closer to 60 gray. And this is a way we can kind of separate these areas into separate dose areas or dose tiers. Lastly, gradient tools are very useful for promoting dose fall off. Common dose shaping tools include things like rings or dose fall off objectives or automated normal tissue optimization functions in the optimizer. For SBRT, you want the dose fall off objective to be as aggressive as possible to promote fast dose fall off. And of course, using non-coplanar beams or arcs can help improve the dose gradient. This is the strategy we use in my clinic. So we have a 1 centimeter ring outside of the target volume called ring HD or ring high dose. And we put a really aggressive objective on the ring high dose. We put a max dose of 1 gray, which of course is impossible to achieve, but it kind of signals to the optimizer, hey, like fall off is really as quick as you can. We give it a really low weight. We give it a weight of 1 times 10 to the minus 5th power. So it's low weight, high, like very difficult objective to meet. And then we tell the optimizer, hey, we want the minimum dose to the OTV, the target volume, to be a little bit higher than the prescription. And then we let these two objectives fight it out. And what the planners will do is they'll adjust this weight for the target volume up and down until they get exactly the coverage they want while still getting good dose fall off. It's sort of like a tuning knob that they'll turn. They'll increase or decrease this weight until they get coverage. And then they'll lock that in and they'll optimize the rest of the plan based on kind of the relationship between the high dose ring and the OTV. And there'll be other objectives in the plan, but really it's the fight between the OTV and the ring that dominate the optimization in our SBRT planning. And this is a really simple way to get fast dose fall off that doesn't require a lot of rings. It doesn't require a lot of complexity. It's really easy to implement, and we find it really effective in our clinic. So I just wanted to give an example of how we achieve fast dose fall off in our clinic for these plans. And then here's the resulting dose distribution. You can see here that, we go from 100% to 50% over the course of about 1.2, 1.3 millimeters, so pretty fast. This is a coplanar plan, and so you can see the dose fall off in the superior inferior direction is a lot faster than it is laterally, but that's sort of a typical plan in our clinic for these types of cases. And of course, we try to get the ITV as hot as possible in the middle. So the ITV is primarily getting 20% higher than the prescription dose or more, with a maximum dose of about 82 gray. All right, last section here. I know I'm running a little bit over, but thank you everyone for hanging in. If you need to go, I understand. I know we're overshooting a little bit with the time, but I'll be finishing up in the next few slides here. All right, so for lung radiotherapy, the typical prescription normalization is based on target volume coverage, typically something like the volume of the PTV getting the prescription dose should be greater than or equal to 95%. So it'd be called the V100 less than or equal to 95%. For prescribing to an isodose line, you want to be careful about the normalization point. Generally, the rule about the normalization point is you want it in an area of the dose distribution where you have the highest confidence you can in the dose calculation. So you want it to be in a high confidence area of the dose calculation, not an area of the dose calculation that's subject to uncertainties. So low gradient is better than high gradient. High gradient areas have higher uncertainty because the dose is changing more quickly. Water like HU is better. So, you want a tissue equivalent point, not necessarily a point in lung, because dose calculation algorithms are generally more accurate in tissue-like materials because the underlying dose calculation kernels are based on water, based on tissue equivalent materials. And then lastly, you want it far away from tissue interfaces like lung tissue or air tissue, because dose calculations are generally better deeper inside of the patient than they are near the surface or near interfaces. So if you follow these three rules, you'll generally have a good normalization point for normalizing your plan. The typical isodose line for conventional lung is between 93 and 98%. For lung SBRT, it can vary quite a bit, between 70% and 85%. Really depends on the hotspot size you want in the middle of your plan. Some physicians want it really, really hot. Others are, more interested in keeping it at a moderate level. This can depend on their training. This can depend on their experience and their comfort level with higher hotspots. But generally 70 to 85% would be typical. With respect to dose calculation algorithms and dose grid, you definitely want to use an algorithm that's well suited for calculating dose in lung. So convolution superposition is very typical in dose calculation algorithms these days. A grid-based Boltzmann solver like Accuros and Eclipse is really good at modeling dose in lung. The AAA algorithm isn't as good as Accuros, but it is acceptable in most clinical trials. But definitely you don't want to use something like a pencil beam algorithm when treating in lung because the dose calculation accuracy in lung just isn't as good with that kind of algorithm. As far as dose grid sizes, my clinic uses 2 millimeters for pretty much everything and 1.5 millimeters for SBRT. The AAPM Task Group 101 recommends less than 2 millimeters or less for SBRT. So if you're using 2 millimeters, that's fine for SBRT. But try to use a dose grid that is as small as possible while kind of respecting what your clinic can achieve in terms of its computing power. One thing to consider for lung radiotherapy is hotspots and dose streaking. So one challenge with lung radiotherapy is that we often try to minimize lung dose, and this can lead to dose streaking in different directions away from the target volume. And I'll show an example of this coming up. But often if you have a really large lung volume and it's really hard to minimize the lung dose, you'll have a lot of AP dose spread to minimize lung dose, and you'll just have a lot of extra dose in the mediastinum. It's sort of an unfortunate trade-off that you have to make to minimize the lung dose, but often that's the best trade-off for the patient. If you're using 6MV and you're using IMRT and you have a small number of fields, you might have hotspots through the surface of the patient. And so especially if you're using IMRT, it's really important to pay attention to the surface dose in your IMRT fields. With VMAT, it's less of an issue because you're spreading that dose out more. But with IMRT, because the dose is more concentrated in a small number of beams, you can have hotspots near the surface. Your hotspot size, ideally less than 107%, but lung tissue is heterogeneous, and the heterogeneity often leads to hotspots in small, high-density regions of the patient, and these can be really difficult to eliminate in the optimizer. And so, hotspots of 110% or even a little bit higher sometimes just are part of the dose distribution, and you have to consider it during plan evaluation and whether or not that dose hotspot can be eliminated. Often it can't be. It's just sort of created by the non-uniform density inside of the patient. For lung SBRT, the hotspot generally is much higher on purpose because you're trying to deliver a high biological effective dose to the patient. And so hotspots from 120% to 140% are typical, and really this should be located in the GTV, kind of right in the center of the target volume. Let's talk about target coverage and dose conformity. There's a older task group called RTOG 0813 that has some really nice quantitative metrics for conformity index, as well as dose follow-up objectives and dose 2 centimeters away from the target volume for SBRT. And we'll look at those in just a second. I did want to note for conventional lung radiotherapy, uniform dose fall-off is ideal, but if you need to minimize lung dose, often you'll have non-uniform dose fall-off in order to minimize the amount of lung dose. And you'll see an example of that in a few slides here. So G0813, which is an older lung radiotherapy SBRT protocol, defines certain objectives for high dose spillage and low dose spillage. And so for high dose spillage, they use the conformity index, which is what you've been talking about in some of your other lectures. And this is the volume of tissue getting 100% of the prescription dose divided by the volume of the PTV. And you can see here in this table that they try to limit that to ideally less than 1.2, and then a minor deviation is considered to be 1.5. For low dose spillage, there is a concept called the R50, or the ratio of the 50% prescription isodose volume to PTV volume. So it's a lot like the conformity index, but instead of having the V100% of the prescription dose in the numerator, you have the volume of the 50% isodose ball. So this is the larger ball that contains the 50% isodose line. And in this case, you can see that the ideal R50 is a function of target size. The bigger your target, the smaller this ratio should be, because the PTV volume gets bigger, the PTV volume is in the denominator, and so as the PTV volume gets bigger, generally the typical R50 value gets smaller and smaller because that 50% isodose ball, typically has, it doesn't get that much thicker as a function of target size. And so you have this continual decrease in the R50 that you can expect. The same is true of the gradient index that you talked about for radiosurgery. Generally, gradient index falls as the target size gets bigger. And this table is sort of a recommendation for how quickly that should fall off as a function of target size. Here we can do a quick example of computing these metrics. So the volume of our PTV can be found by looking at the DVH, where the dose is 0. Here we see that it is 38.6 cc's. The V100 can be determined by looking at the external contour at the prescription dose, and here we can see that it's 44.5 cc's. And then the V50 can be gotten from the external contour at 50% of the prescription dose, which is 25 gray, and that's 142 cc's. And then we can use these numbers to calculate the R100 and the R50. For this plan, it is 1.15 cc's and 3.2 cc's. And then lastly, we can go down to this table and look for a target volume between 38 and 50 cc's. We want a conformity index less than 1.2, which we achieved, and a R50 less than 4.3, which we also achieved. And so in this case, this plan met both objectives. I wanted to show an example where we have kind of poor dose fall off, but for a good reason. Here we have a pacemaker. This pink area is the patient's pacemaker. And we're treating a lung SBRT target pretty close by, about 10 centimeters away on the opposite side of the lungs. In this case, we're blocking the pacemaker entirely during treatment, so no photons will enter it or leave through it. So that's entrance and exit blocking. We're using 2 coplanar beams and some non-coplanar beams in order to spread the dose around and try to avoid the pacemaker as much as possible. And you can see here that the conformity is pretty good. We have a little bit of dose spillage of the target dose outside of the target here, a little bit of spillage. This is actually 2 targets that are merged together. So we have a little bit of spillage where they're kind of coming together. But really the low dose fall off is what you notice as being kind of unusual. It's very anterior posterior because we're avoiding the pacemaker. This is the case where we had to accept less than ideal dose fall off in order to protect an implanted cardiac device. And occasionally this kind of thing happens when you're protecting an organ at risk or a device. I just wanted to show an example of what that looked like. Here's a case where we are treating a really large, long, conventional radiotherapy PTV. And in order to meet the lung objectives, we had to stretch the isodose lines more in the anterior posterior direction and less so laterally to reduce the amount of lung dose that the lungs are getting. And so you can see the uniformity of the dose fall off here isn't very good, right? In the anterior posterior direction, it's kind of slow. In the lateral direction, it's actually pretty fast. But we did this on purpose because we wanted to minimize the lung dose. And this is something that you'll occasionally see where you don't have uniform dose fall off, but it's by design. It's reflective of the physician's intent. And that's okay. With respect to organ at risk sparing, this is where it's really important to have a good directive from the physician about which objectives take precedence. In my clinic, we have these treatment planning orders where we specify what are priority 1 constraints and what are priority 3 goals. Constraints have to be met. Goals are nice to have, but target coverage should come before the meeting the goal. In this case, the physician wanted constraints on the bronchus, the trachea, and the esophagus. And you can see here we undercovered the bronchus and the esophagus in order to meet those objectives. So this is a plan that met the physician's intent, and an important part of plan review is making sure that that intent is met. And what I said on the last slide certainly applies to this one. Sometimes meeting DVH metrics for organs at risk must be done before target coverage. And so the most important thing is to have a clear directive from your physician and know exactly which targets have higher priority than organs at risk and which organs at risks have higher priority than the target volumes. Last but not least, I'll just mention composites with prior RT.
Sorry, Dustin. If I may interrupt you, I apologize. But
absolutely.
For the previous slide, somebody asked earlier on what constraints are used for a brachial plexus. My recommendation was to look at RTOG or high tech or one of those publications. Do you have anything to add to that?
Not off the top of my head, but yeah, I'll look that up and I'll share that with Emily, and I know Emily will share that in her weekly email. So I'll get back to you on that. I just want to confirm with my physicians what the most up-to-date objectives are being used. My guess is if you look at LU008, there'll be some really good objectives in there, but I'll double check before I answer. I don't want to give the wrong answer.
Thank you.
And what you see here is for the 15 fraction regimens. I wouldn't copy and paste from this. This is a 60 gray and 15 fraction. So this is kind of an unusual dose fractionation. And it does depend on the dose fractionation. So I want to make sure that we provide the right information. So back to prior RT. It's often the case in lung that we're mixing different dose and fractionation. So you might have conventional mixed with SBRT, breast radiotherapy, and then SBRT later on. And so when you have different dose fractionation regimes, like adding SBRT to conventional, it's good to use EQD2 and not add the physical doses directly because that makes it more difficult to interpret the composite dose. If you don't have software to convert 3 physical dose distributions to biological dose, one conservative choice is that you can convert the physical near maximum dose for different organs at risk from each plan to EQD2 and add them together. So let's say you have a spinal cord dose, a near maximum dose of like 50 gray from a conventional plan and 12 gray from an SBRT plan. You can take those 2 numbers, convert them to EQD2, add them together, and that will give you a really conservative worst case scenario sense of what the spinal cord dose could be. It's unlikely that those 2-point doses are in the same location, so it's very conservative, maybe too conservative. But you certainly won't be in an unsafe scenario if you're adding the maximum doses together. So that's one option. And I know this is a really big challenge. Not all clinics have software to convert 3D dose distributions to biological dose. And so I think we're at a moment in our field where we need better tools for all clinics to be able to do this in clinical practice. And right now there's some nice resources out there, but the typical tools available in every clinic aren't always ideal for adding dose distributions together. All right, last poll question. You're reviewing an SBRT treatment plan. What dose metric would you use to quantify high dose spillage?
You should be able to see the poll on your screen. All right, Dustin, we have about over half of participants have already answered, so I'm gonna end the poll, and it's pretty spread out.
Indeed it is, yeah. So the correct answer is the R100. The heterogeneity index it's typically a ratio of the 150% isodose volume divided by the 100% isodose volume. That's typically used in brachytherapy to kind of define how much 150% is in the dose distribution. The R50 is the dose metric that we use for low dose spillage. So this is the 50% isodose volume divided by the PTV volume. The R100 is for high dose spillage. This is the same as the conformity index and tells you how conformal your prescription dose volume is to your target volume. And the maximum dose to the normal 2 cm is another way to quantify the low dose spillage. Let's continue. Just a couple more slides here. Communication plan. For lung radiotherapy, there's a few things that as a physicist you can communicate to the therapists who are going to be treating the patient that can help them with their decision making. If a patient has atelectasis, it can be important to remind them that they should monitor the patient for large changes in the lung anatomy. And if there's big changes in lung anatomy, you might want to replan, and the therapist will be the first people to catch this very often. So it's good to have good open lines of communication between the therapist and the physics and dosimetry team, in addition to the physicians. If there's any sort of special instructions related to arm positioning or clearance concerns or critical anatomy for alignment, this should be communicated to the therapist. This includes things like motion management instructions. And finally, if there's multiple targets being treated with multiple plans, the relationship between plans and target volumes should be communicated very clearly, because very often all of the target volumes are included as contours for each plan, and it can be really difficult at a glance for a therapist to know which targets are being treated by which plans. One way that we do this in my clinic is that we often try to synchronize the name of the plan with the target names. And so you can see here that we have a plan name of PTV13 treating PTV1 and 3, PTV2 SBRT is treating PTV2, PTV4 is treating PTV4. And we'll also create a patient alert that explicitly says which targets are being treated by which plans, just to give the therapists a better chance to review and understand which targets are being aligned, what's the target anatomy, and make sure that they're aligning to the right targets every day. Generally, with one target, this isn't an issue, but with 2 or more targets, this is something that can be a potential hazard. Last but not least, if you have any deviations that you discover, you should have a system for capturing and learning from these. I wanted to share that almost all of the examples in this presentation come from our incident learning system. So I kind of went in there and I searched for lung, and I tried to find interesting things that we had caught and corrected as part of our treatment planning workflow. And so if it weren't for our incident learning system, I probably wouldn't have had so many examples to share with you today. And I think it illustrates the value of having an incident learning system and being able to capture those lessons and learning from them later on. And in this case, sharing those lessons so that other people can learn from them as well.